Good afternoon, everyone. We are now live on YouTube. Welcome to Patient Advocates Transforming Healthcare PATH Tuesday Table Talk. My name is Hala Dura. I am the founder of PATH, and I'm also a patient family engagement consultant. I'd like to welcome our audience today to our table talk. Today's topic, the moral determinants of health. I'm really excited to welcome our guest today, Dennis Wagner, a former senior executive from the Centers for Medicare and Medicaid Services, and currently now serves as a healthcare and leadership management and healthcare and leadership and management consultant. My apologies, I got tongue-tied today. And our topic today is based on an article written by Dr. Don Berwick that was in JAMA in June of 2020 of this year on the moral determinants of health. And as Dennis will jump into the conversation soon, this article really touched a lot of points that so many of us have been discussing over the course of the last few months, particularly now in the midst of a pandemic and the national conversation around racial injustice and structural racism. And I found the article really to be a call to action for healthcare in general, more specifically physicians, nurses, administrative leaders, politicians, and I would say, and I will speak on behalf of being a patient family engagement leader, a call to action for ourselves and our communities as well. I think the way Dr. Berwick really framed the article was so eloquently written and really touched upon a few points that I want to share before we jump into the conversation. He began the article speaking about the moral law within, and that being really the basis of a just society, and the power of societal factors to really determine one's path. And we know this all to be true, sadly, in healthcare, where your zip code, your background, the color of your skin, the community you may be from, can really determine your healthcare pathway. And he even shared a specific example about the subway map in New York City and how from going from Midtown Manhattan to the South Bronx, there's a life expectancy declines by 10 years. And that to me was such a striking component of what we're talking about when we talk about moral determinants of health. As I alluded to earlier, our national conversation around structural racism and racial injustice have really been one of those topics that we've always known has existed in our society and specifically within healthcare, but now because of the pandemic have been just amplified and magnified. We know that some of the politics involved have been great barriers to some of the healthcare improvement we all seek. And we all know that part of that moral determinants of health that Dr. Berwick talks about is really about solidarity and shared responsibility as a society, and how can we support one another to live better, to be healthier. And he outlined really nicely in the article as well an agenda for action. And as a former political science student, I really appreciated many of the points he brought up in that agenda. And then towards the end, he talked really about that call to action that I prefaced this article about, and what we all need to do, how we all need to speak up to mend the fabric that he so eloquently described as being torn. What is our shared goal of health? And how do we really work towards that reform that benefits us all of us? And so I will stop there with I'm sure not doing that article justice, but hopefully giving our audience a really quick overview of the article. I'll be sure to post the link after our talk is completed today. But Dennis, I'd like to kind of start there. And in that call to action, one of the questions that Dr. Berwick posed was, what is healthcare's lane? And so from your perspective and your conversations with your friend and colleague and other healthcare leaders, what is healthcare's lane right now?
Yeah, thank you, Hala. And I'm very honored to be included in Table Talk today, so I want to thank you for including me in that. And I feel compelled to say kind of two things before diving into the question that you raised. One is, I'm not Don Berwick, right? So I didn't write the article. And he is, just for me, an extraordinary mentor and example of what it means to be not just an effective national and international leader, which he is most definitely, but an authentic and caring human being, which Don Berwick also, I'd say, is always at the forefront of any interaction that I've had with Don over the years. So I just want to acknowledge that, I'm not Don, but I'm gonna do my best to sort of reflect on Don's writing in this particular article. The second thing I'll just say by way of preface is that by just sheer good fortune and coincidence and a variety of factors, I've had the opportunity to have probably, 12, 15 meetings with Don in the last 30 days. So I've been interacting with Don a lot over the course of the last month, and I've heard him speak on probably 10 different occasions now about the very topic that we're discussing today. So I do feel very close to and steeped in some of his thinking on that. And, to get to your question then, like, what is the proper lane for healthcare around these moral determinants of health? I will just say that, Don is very clear, I think, in his article. He poses it as a question, but then he ends the article with an assertion or a series of assertions, right? And he says at the very end that healers are called to heal. And when the fabric of communities upon which health depends is torn, then healers are called to mend it. So he kind of answers his question from his perspective as a healthcare clinician, a provider, and a national and international leader in healthcare, that yes, healthcare needs to involve itself fully, in mending this torn fabric. And I couldn't agree more. I'll just say I think that is absolutely correct. And two additional points I would make about your question. One is that I've had the good fortune dating back to, I guess, about 1997 is when I became, for the first time, involved in the profession of healthcare. I transitioned from a federal accountability and the U.S. Environmental Protection Agency to HRSA, where I joined work on a campaign to increase access to healthcare for the nation's most vulnerable patients and to reduce disparities. And what I learned beginning in 1997 through the next 23 years of federal service that I had at HRSA and CMS is that my experience with healthcare providers is that they are in it to heal. They are in it to help people. They are in it to make things better for the patients that they serve. And so in leading quality improvement efforts, having goals, like health outcome goals, goals that sort of relate directly to the well-being of patients, was far and away the largest motivator for the healthcare communities that we're calling on to improve. Whether it's increasing organ donation or increasing the use of transplantable organs or improving hospital patient safety or increasing access to healthcare. On all of those fronts, I would say the number one motivation by far of the healthcare provider was helping and healing, that is their central motivation. And they're caught in a system that makes that difficult for them constantly. And so as I interact with healthcare providers, they're frustrated by the payment system, and they're frustrated by the technical and measurement systems and all these other things. So my sort of net on that is that Don is calling on healers to heal, and healers, in my experience, they want to heal. Like, that is their principal motivation. And I think that's a great blessing, for the nation and for those of us that rely on healers to heal. The second thing I would say, though, and maybe we can talk further about this, time permitting, is that I also believe that all of these other parts of society have much to contribute, and my experience with healthcare quality improvement is that patients and family members that I have worked with over the last 23 years in this work have contributed immensely. And I don't mean on the edges, I mean have contributed immensely to making things better. So I wouldn't limit it to healthcare providers by any stretch, right? And I don't think Don intends to in his article. And he is very clear. I think that his belief is that we should be calling on healthcare providers to address the moral issues and the moral questions and the moral determinants of health.
Thank you, Dennis. So I wanted to reflect on a couple points that you brought up. And I also would like to remind our audience that if you are signed into YouTube, please do feel free to share your questions in our chat box, and we hopefully can get to some of those before the end of our talk today. So you did mention patients and family involvement and engagement, and I know you've been such a champion of patient-family engagement over the years. And that is one of the ways I've gotten to know you over the years, is our work together in that realm. And I'm just wondering, what specifically do you see as that role currently, and where could it really go to really support this healing concept of mending that fabric and really being more engaged in changing these moral determinants of health and supporting a more equitable health care system? What do you see as the role now, and where do you see that role possibly going?
Yeah, so that I'm sure I could give you a 20-minute answer, so I'm gonna have a hard time, but I'm gonna try to limit myself here on this. I have always felt that there are three compelling reasons for patients and family members to be integrally involved in healthcare. And I would say that number one is it's the right thing to do. Like, the patient and their family have more at stake in the outcome than anyone else. Like, and it is necessary then, and appropriate and right, and I would say morally right, that they be involved in the choices and the decisions that impact their care. So that would be number one. Number two is it's the smart thing to do. Like, any student of organizations, change, improvement knows that if an organization is going to increase the value of what it's providing to its customers, that you have to listen to the customers, and that they're the best source of information and the best source of learning, innovation, change, and improvement. And this is the United States of America, where the consumer is kind of at the forefront of change and improvement throughout all of our systems, whether it's transportation or airline safety or buying groceries in the grocery store. Like, we listen to consumers, and then we adjust to make the value and the quality of our services and our products better. And then I think the third thing is that it works. And that kind of takes me, when I say it works, what I mean by that is, from my point of view, as somebody who has made a career out of working to achieve at national level social change and improvement, whether it's making hospitals safer or saving more lives through organ donation or some of these other kinds of things. And when I say that patients and their families have a role to play and that it works, I'll just give you kind of one example. I met this woman in 2004. Her name was Susan McVeigh Dillon. She's a special education teacher at a high school in a suburb of Pennsylvania. We invited her to come to Dallas to speak to 136 teams of doctors and nurses and caregivers in the nation's largest trauma centers. And we wanted her to speak about organ donation. And the reason for that was that about a half a dozen years prior to this, she got a call one day at school at about 4 p.m. that she needed to come immediately to the hospital. And so she went to the hospital, and a social worker met her at the door. And she knew this can't be good. Like, this is, a serious problem. It was about her son. And she knew that when she got the call. They told her. And what she discovered is her son, who was a freshman in high school, had gone rock climbing after school let out that day with friends and fell from the face of a cliff and suffered a traumatic brain injury. And over the course of the next 3 or 4 days, she and her husband and her son's sister learned that Michael would never wake up. He would never be able to feed himself. He would require a feeding tube. He would never be able to breathe without the assistance of a ventilator. And over the course of those 3 or 4 days, she and her family made really the toughest decision that anyone could ever make about a loved one, which they decided to remove life support, knowing that when they did that their son would pass. And after they'd made that decision, Susan said to the medical team at this hospital, it was a small suburban hospital, that she wanted Michael to be an organ donor. And they said, oh, we can't do that. And she's like, well, what do you mean you can't do that? Like, he's 14 years old. Like, my God, his organs could save the lives of other people, like other mothers could take their sons home from the hospital, if he became an organ donor. That was her thinking. They said, well, he has a residual amount of brain activity, so he's not technically a brain dead patient. And the only way we could actually do organ donation is after life support is removed and he undergoes natural circulatory death. And we don't do that in this hospital. And she's like, well, why not? And they said, well, we'd have to go through these committees and, the ethics committee, and we'd have to consult with the CMO, and these people would have to be convened. We'd have to establish a new policy. And, we've just never done that. And she said, well, you need to start now. And they refused. And she made a moral decision. And her moral decision was, if another mother can take their son or daughter home with one of Michael's organs, it's going to happen. And you guys are going to figure it out. And she held the line, and they called the organ procurement organization in Philadelphia. And they came out and they said, well, there's only one other OPO in the country in Madison, Wisconsin that does this, but they do it all the time, and it's very effective, and it's very appropriate. We've never done this before, but we'll work with Susan in the hospital to make this happen. And they did. So then, 6 years later, the situation is that 4 of the 58 organ procurement organizations in the United States were doing this. It's called donation after circulatory death, and it saves lives. But most didn't. And so Susan spoke to this group of about 1,000 people in Dallas from these 136 large trauma centers. And I'll never forget, at the end of her talk, she told Michael's story. She told what happened. She showed pictures of the young man who got his liver, who had 2 young sons. His name was Santos. And it was incredible. It's absolutely incredible. And then at the end of her talk, she said, I'm a special education teacher in high school. And in my classroom, the words I can't and I won't are not allowed. And as leaders of the nation's largest trauma centers who could save thousands of lives through donation after circulatory death, I expect no less from each of you. And honest to God, Hala, it was probably the most moving talk I've ever heard in my entire life. I don't know if there was a dry eye in the house. And people stood up and they applauded her, and then they went to work. And I'll tell you that today, 20% of the organs that are transplanted in the United States come from donation after circulatory death. And her stand, that first one in that hospital with her own son, and then her stand after that as a national leader, had just an extraordinary impact. So when I look at Don's article and I see he's calling for healers to heal, and I know the power of us as patients and family members, right? In addition to all these other forces, the political forces and the administrators of hospitals and the leaders of food banks and the CEOs of big businesses, like all of these people, all of us should care about these social determinants of health and should be in action on them. But I'm sharing this example with you because of the nature of the work that I know you do and that you're committed to, Hala, and that many of the people on this call are committed to. And if I had a single point, a bottom line, if it's not already clear, is that all of us should care about this. All of us should be in action on this, and our actions, like Susan McVeigh Dillon's actions, can make a difference.
Thank you, Dennis. And it's really powerful story, and it actually gives me chills because, as you may know, my daughter received 2 liver transplants within 2 days of each other. And I wonder now, Susan's actions may have impacted our own family's journey and our family's story. So I appreciate you sharing that. And, that just speaks to the power of the story. When people share their stories in a way that is impactful, the change that they can make because of it. And as I look in the chat box, one of the questions that came through was, how do we get healthcare leaders to understand the true value of the voice of patients and families? And I think for me, as I reflect on my work, I understand the power of the story. But to be quite honest, sometimes the power of the story isn't always enough to convince leaders that change is needed, so desperately needed. And so I want to pose that question to you as someone who's been in healthcare for many years and is a person that we all look to for many of these answers. How do we get healthcare leaders to understand the value of the voice and specifically that story? What would you recommend we do to really make that be something that doesn't always have to have a lot of data behind it? Because a lot of times it's show me the data, right? Show me why this should make a difference, why we should do it. And so, balancing that quantitative and qualitative is a real tightrope walk. And I'm wondering, how would you answer that question? How do we really get leaders to understand the real value of that voice?
Well, you're not asking easy questions here. um, I think I would answer your question, or I'll try to, in the spirit of the way you asked it. Like, healthcare leaders, clinicians especially, ground their work in science and data, right? So if you're going to make, a compelling argument to someone in that field, I think you should bring data to it, right? And there is data, that I'll just, you may not, well, the example that I gave just a few moments ago of Susan McVeigh-Dillon's work, right? At the point in time that she spoke to that group, there were about 400 people who were what were called DCD donors that year. And today, it's 20% of all donors nationally, right? So it's on the order of nearly 10,000, right? So that's data, and that data is directly related to, I would say, her leadership. So I think the first thing I would say is, I think whenever possible, we should bring data to these discussions, and the data is there. You may have to look for it, or you may have to learn it from other people and master that, but it's there. Now, the second thing I would say, and this kind of relates pretty directly, I would say, to the moral determinants of health and Don's article, is that ultimately many of these questions are moral questions. And I think we have to understand that first, right? And then having that understanding, I would say 3 more things then. So if you know that at base, some of these questions are moral questions, sort of like the Affordable Care Act. Like, a lot of people want to make that a technical question or a legal question, right? And we're going to have a case in the Supreme Court here to kind of hear, is it constitutional or not? But at base, one of the key issues with the Affordable Care Act is that 21 million people have care today that didn't have it before the Affordable Care Act, largely as a result of the Medicaid expansion. So we made a decision as a society that we were going to provide care to those people, and we've been doing it now. Same with the pre-existing conditions, which is another element of this. And people, I think, like to turn these into technical or legal issues, but at base, they are moral questions, and they involve moral decisions by individuals and by society. So when you're in that situation, and this brings me to the 3 things I would say. The first is that I think in my life and in my work, I've learned that if you want change to happen, like if you want the patient voice to be heard, and you want the patient voice to be integrated, and you want it to have an impact, all right, you have to consciously commit to that and say, I'm committed to that. And even when it's difficult, I'm going to remain committed to that. I'm going to stand for that. Now, you can stand for it loudly, you can stand for it angrily, you can stand for it passionately, you can stand for it with reasonableness. There are all sorts of ways to stand for it. But you have to decide, I think, and consciously commit that this is something I'm going to stand for. I think the second thing, and I would say this is particularly true with moral questions, is you have to be prepared to be comfortable being uncomfortable. Which is one of the hardest things in my life for me ever. Like, I want great things to happen, but I'd like it to be easier than it is, right? And I'd like it to be more comfortable than it often is. And there are lots of times that it is comfortable and happy and aspiring and inspirational and all these other things, but there are these other times when it's deeply uncomfortable. And I think we just have to be prepared that we're going to be in uncomfortable situations when we stand for it. And then I think the third thing I would say is have faith. And when I say have faith, I don't mean in an abstract and hypothetical way. I mean that, as Martin Luther King said, the arc of history bends towards justice. And I see that. I see that. That's pretty clear to me that we're imperfect. This nation is very imperfect. Our founding documents are imperfect. It's taken us a long time to make the improvements that we've made. I think we should have made many of them faster and sooner, and there are many that are not yet made. That's why we're having the unrest in the streets and concerns over policing and all these other, things that are crying out for improvement in our society. But I think at base, I've learned that best practices can become common practices, and that when people of good faith and goodwill seek to bend that arc of history, closer to justice, that we do it, that we succeed in that. And it's rarely easy, and it's almost never comfortable, I guess. It might be another way to say it. But we can do it. And I've seen that in my own work, in a more technical and administrative and healthcare domain. And I've seen it writ large in society. And I think that to kind of persevere through that uncomfortableness and to remain with the commitment and the stand in the first place, that we have to have faith. And I see lots of evidence that we should have faith.
I agree, and I also hold on to the hope that we have that faith and continue to have that faith in this work, because certainly it does require a lot of grit, a lot of resilience, and as you said, being uncomfortable and preparing to be uncomfortable. And I know I've had many conversations over the last several months where we tell one another, if we're feeling comfortable, then we're not making the change. We're not doing the work right now. And so I couldn't agree more with that statement. Now, in the last couple minutes, I did want to just finish up with a question we had in the chat. And thank you to our audience today for all of your great questions and comments. Going back to the article and when I was kind of giving the overview, I brought up, structural racism. And that came through loud and clear in Don Berwick's position in that piece. I'm wondering, in these last couple of minutes, if you could reflect a little bit about what do you think healthcare's role is in fighting structural racism and supporting the types of social reform that we've alluded to during our conversation? Love to just get your final thoughts on that.
Well, that's another challenging question, Hal. I think, and this comes more from my own, I think, personal experience in life. I would say that, the first thing, and it's kind of at base, is you got to understand that this exists, and that its existence is causing all these bad things to happen. And when I think a lot of people for a long time have been in denial about that. And I see that now. I didn't fully appreciate it, I would say, before George Floyd. I view myself as someone who is discerning, who is thoughtful, who cares about others, who cares about issues like structural racism. But I don't think I personally fully understood the magnitude of it until I witnessed what happened with George Floyd. And I think that's true for a lot of people like me, people who care, people of goodwill, people who want to do the right things. And I think that's most of us who want to do the right things, who care and want to make things better. That's my experience in life, that most people fit that category, those categories. But I think George Floyd and some of the things that happen after that, that are happening up until this day, I think our eyes are opened. And so I think the first thing as healthcare providers is really kind of understanding that, accepting that. And then once you do that, I think the world presents you with opportunity after opportunity after opportunity to act on it. that has been my own experience, and I think that will be the experience of healthcare providers, and it will be the experience of patients and family members who want to improve healthcare and who want to address structural racism, whether it's in healthcare or other domains of life. I know I see now. I just see things I didn't used to see. It's sort of like the scales have been lifted. In some ways, and we can do better. And we just need to take the actions individually to make it better, I think, individually and collectively.
Thank you, Dennis. I know we could talk forever about this topic, and I really do appreciate your time today. Sadly, we've come to the end of our table talk for today, but as you said, we all have a role. We all can commit ourselves to making things better and really truly addressing these moral determinants of health, because ultimately it does affect us all, and we all owe one another the support and solidarity to live healthier and happier lives as a society. So thank you so much for joining me today on our Path Tuesday Table Talk. And thank you today for our audience for joining us today. We come on every Tuesday at 2 p.m. on our Path YouTube channel. Please do check us out. If you haven't been able to catch us live, all of our talks live on YouTube. So please do go back and check them out. Again, thank you, Dennis. Thank you for your public service to us. Thank you for your leadership. And thank you for being a champion for patient-family engagement and in the healthcare space. We really, truly appreciate it. And I'm going to ask you to just pause on mute for a little bit while we close our stream. And thank you again to our audience. Please do join us next week, where our topic will be policy, politics, and patient-family engagement, understanding the power principle. So I hope you all will join us next week. And thank you again, Dennis, for joining us. And we'll be closing our stream in a few seconds. So hang tight. Thank you all and have a great day.